if that's okay.
Okay, cool. Well, I think I mentioned to you, we're going to have, we're actually developing our online CE program. So this is pretty much it. Although there's two components. One is the training, and then although it will entail some more videos, and then we're going to have our implementation portion for practices that, offer it maybe for a price. It seems to be one of the bigger challenges that we have for offices. It's how do I get patients to accept? So anyway, we're going to have some online training stuff available pretty shortly. So if you want to get CEs for it, you can just redo it. So with that, great to see you again, by the way.
Yeah, and this is Kara Reck. She's
Hey, Kara, how are you?
Hi. And we have Dr. Bogey from Iowa with us too.
Fantastic. Hey, doctor.
Hi.
I guess if something doesn't sound clear because of the transmission, let me know.
Okay.
All right, so I'm just going to get into, so you may already have some of these statistics already, but I think especially sharing these with your students, hopefully will be beneficial because no one really understands or knows about these statistics. You're frozen. Can you hear me? All right, I'm sorry. Well, you're frozen, but as long as you can hear me, then okay.
I can hear you.
All right. So the reality is, one of the things we stress is that, if you look at the mid 70s to early 2000s, the rate of oral cancer was pretty much consistent, fairly slight increase, but all of a sudden we see this pretty sharp increase, even though we actually have less smokers, obviously, which at one time was the leading cause for oral cancer. And so this is a great conversation, as you're teaching your students. I would say, hey, what do you guys think are some of the 10 to 15 top cancers out there? And everyone will say, lung cancer, breast cancer, cervical cancer. A lot of women will say prostate cancer, skin. No one will put oral cancer. And so this really provides, hopefully, a sense of awareness that helps them understand the prevalence of this. And it depends on the year. Some years it's top 10, others just 13, 14. But at the end of the day, it's one of the top forms of cancer that isn't recognized. And so putting this into context, one of the things that women hopefully get every year are pap smears. And unfortunately, the women who get cervical cancer now are women who don't get annual pap smears. And we put this in comparison, though, 4 times as many oral cancers as cervical cancers. And what's the connection? We all know it's HPV. Obviously, the leading cause of cervical cancer is now the leading cause of oral cancer. And because of that, what people don't realize is that just like cervical cancer is a viral disease, oral cancer is now a viral disease that affects both men and women. You guys hear me okay?
Yeah, definitely.
All right, awesome. And you're seeing the screen too.
Yeah.
You see the screen? Okay.
Mm-hmm.
So, some of the initial studies, and I find this tends to be somewhat salacious, when you talk to your students, but, some of the initial studies was about oral sex transmitting the virus, Michael Douglas, but the reality is that the virus can now be transmitted through open mouth kissing. I was on a conference on Friday where a clinician was talking about it being diagnosed in a adolescent. So the virus can be transmitted fairly easily from what we understand now, which means everyone's at risk. Doesn't matter how many sex partners you've had, doesn't matter if you've had 1 or 10 pap smears. At the end of the day, we just assume everyone's at risk regardless of who they may have been in contact with, because you just don't know, obviously, and men don't know about that risk or if they're infected or not. One of the things that's come up as well is some recent studies that have shown that women that have had abnormal paps actually have a higher risk for oral cancer. So, when we look at all these characteristics of, number one, white males tend to have the fastest rate of oral cancer, although white females actually are gaining in terms of an increase, and they think possibly it's because of this link between abnormal PAPs and HPV, obviously, and therefore oral cancer. So the people that we want to screen, obviously, are all our patients above the age of 40, and these are our recommendations. Obviously, all your smokers, your heavy drinkers, those that may have a poor diet.
We do.
I have some at the top of there.
Didn't they have some at the front?
I have a pink one in the very top basket. Yeah. Yeah, top drawer towards the back. Sorry, Evan.
That's okay.
So, so Evan, this, you're gonna be able to show us how to use this too, right?
Yes.
A little bit? Okay, cool. Sorry, that was like the thing I'm most scared about. So thank you so much.
And I'm going to send you additional video that sort of goes through the whole process, but we'll definitely
Okay.
go through it in terms of what we're looking
Okay,
at.
great. Thank you.
So basically, every patient that's above 18, we want to screen. Once a year is the norm. Obviously, a patient of higher risk perspective, then you can screen more frequently. One of the things, and I guess this is really critical, team that you're doing in terms of educating your nurses, is how to do a thorough oral health intra and extra oral exam in the first place. So we stress that VELscope is part of your overall assessment. So you still have to do Q&A with the patients, review their health histories, medication changes, and so forth that obviously can impact their oral health. You then do a white lighted intraoral examination, and then we're going to do our VELscope examination. We see things under white light that will allow us to focus a little bit more on that area. Like, Mr. Smith, I noticed something on the roof of your mouth. Maybe if you jabbed yourself with a utensil or something. Not sure. Well, obviously that's something we'll focus on with VELscope. We may see things under VELscope that we don't see under white light. I see a little, and we'll talk about, a little grayish area in your cheeks. Jim, are you biting your cheeks? Oh yeah. So obviously that provides that correlation, but we're going to follow the protocols. If we see something suspicious, we're not sure what it is, unilateral regular persists for 2 weeks. Then you can follow your protocols of assessment and assistance. My question for you, so if you have a nurse who's doing a white light exam, they see something suspicious, what's the normal protocols for referral?
So it's a normal protocol for referral?
Yeah, recommendation.
With the nursing students, well, right now, like if they found something at one of our events, then we would probably do most of the referral with them. But a lot of what we're using it for now and teaching them how to use these kind of things is more along the lines so they can implement it into their practice, someday. And hopefully they're working in an office where whatever physician they're working under would do the referral.
Gotcha. Yeah, and so that obviously then you can have that follow up at that point in terms of the process. So be that as it may, and again, I know how much in depth you get into with your students. What we stress is that 30% of your patients will have some form of abnormality, right? Whether it's fibroma, cheek biting, whatever. And you should always have some type of assessment of what it is to ensure that it obviously isn't something potentially cancerous. So differential diagnosis, or, obviously sending picture, whatever, to a specialist for consultation. The key point here is that oral cancer is found at late stages. We obviously want to find it earlier. And that's where VELscope helps us, is to find it at the earliest possible stage below the surface where you can't see with the naked eye. So the way this device works, first and foremost, we always stress that it's safe. There's no radiation, there's no obviously stains, there's nothing that causes cellular damage. It's not like a curing light, so if you happen to look at it the wrong way, it's not going to cause damage to your eyes, but it is bright, so that's why we provide the goggles for the patient, for patient comfort. What we're doing is we're exciting the collagen in the basement membrane, so when the collagen is normal and healthy, and we turn it on, that's when we see green, looking through the filter. When we have dysplasia or cancer, the first thing it wants to do is grow, and in that process of growth, it starts to break down the collagen. Once that breakdown occurs, it can't respond anymore. So instead of seeing green, we see darker black. It's pretty simple. Now, just because we see darker black doesn't mean we have cancer. It means there's something abnormal that requires further assessment, and we'll go through that process of how to assess. So these are all the things that are involved with determining if the tissue is normal and healthy. That will appear green. So when our collagen's in a normal state, when the keratin, when the metabolic rates, believe it or not, which we identify in the cells, are normal, it'll appear green. When we have dysplasia or cancer, because of a breakdown in collagen, because an increase in metabolic rates, we will see darker black. Two other things that absorbs this wavelength, which is important: melanin. So African Americans, Asians tend to have more melanin, for instance, in their tissue. So we'll see more dark there. And then hemoglobin, which is in blood. So hemoglobin absorbs this wavelength, which is actually great for us because we're going to be able to more effectively differentiate between dysplasia and trauma inflammation. So 98% of the time, all you're going to see is healthy green tissue. If you notice here, we see vascularity, and that's the hemoglobin that I referenced, but most of the time, again, nothing but green, healthy tissue. Again, we're utilizing all the techniques which you're teaching your students in terms of how do you assess unilateral versus bilateral or regular shape persist for 2 weeks, palpation, firm versus soft. Here, obviously, we're getting into spring. Allergies are going to be more common, so it's not uncommon to see irritation in the back of the throat. And under VELscope, that bilateral presentation will probably stand out a little bit more than normal. But again, bilateral, and again, that vascularity from the hemoglobin is what we're referencing here too. So if I put VELscope in your hand and said black is bad, right? You never heard about it, you never heard anything about how it works. And then you see this patient's tongue, you might think, oh my God, what's going on here? And what we're actually seeing is increased blood flow to our taste buds. So that increased hemoglobin. So what we're seeing is just, taste buds, and this will be varied from one patient to another, but we know oral cancer doesn't grow in polka dots. It doesn't grow randomly. It doesn't grow in little shapes, right? It's going to be unilateral or regular shape, persist for 2 weeks. Now here we see a black mass. That says more concern, right? Hey, Mr. Smith, I know something in the back of your throat. Do you have allergies, postnasal drip, something that's causing some irritation back there? And the patient's like, nope, not that I know of. Has the patient come back in 2 weeks, still there, hasn't resolved. Sends them to an ENT, but with a sense of minimal concern. And the reason being is if you start looking, you can start seeing a lot of little black polyps all there. And it'd be too obvious if I opened up the full picture here, but these black polyps are numerous, which reduce our concern, but there's still something, it's not, don't know what it is. ENT immediately takes a biopsy. I don't know what the heck it is. It comes back as a plain lymph node tissue. Not sure initially what it is, but about Q&A and follow-up, patient ends up getting tested and was identified with severe acid reflux and didn't even know it. So this is actually something you're going to see pretty frequently, probably more just like these polyps right in the back of the throat. When you see it, first question you want to ask is acid reflux. One of the fastest forms of cancer in the US, esophageal cancer, acid reflux. So this is really important. So when you see it, make sure you have a conversation with the patients or obviously, students when they see it, identify it. Because for obviously primary care, this is the perfect scenario to have that conversation with. So red or orange, especially on the dorsal surface tongue, has nothing to do with cancer. It's just a bacterial response, but definitely worth having a conversation about brushing their tongue or scraping their tongue more effectively. So white or light green for us generally is a benign state, but doesn't mean we ignore it. So we sort of see a little white line here. Want to suggest maybe looking at their teeth, see if there's some rough edges here. You can see a little lesion that's white under VELscope. And upon conversation with the patient, Ms. Smith, I see this little area. Do you know what's going on? How long it's been there? Oh yeah, my tongue gets caught between my teeth every now and then. So boom, that can be taken care of. So I mentioned pigmentation absorbs this wavelength. So when we see something under white light that we identify as pigmentation, it should pretty much be analogous to what we see under VELscope, right? Same shape, size, same thing with this amalgam tattoo. So I mentioned hemoglobin absorbs this wavelength. And the problem is that if hemoglobin absorbs this wavelength and it's gray or dark, and we have a cancerous lesion that's gray and dark, how do we differentiate between the two? And the way we're going to do that is when we see something abnormal, we'll take our Explorer, turn your mirror around and use the skinny, little end of your mirror and gently rub across it. And if you see it turn green, as the hygienist is here, what we're seeing is the hygienist is pushing the blood out of the epithelium and seeing a nice, healthy base of membrane. So we're seeing nice, healthy collagen. So what this means in this particular case, this is a denture sore, and we're just confirming it's a denture sore. If this stays dark when we rub across it, we're not sure really what's going on, why it's there, patient's not sure. adjust the denture, but we definitely want to have this patient come back in 2 weeks. Here we know, okay, denture short doesn't mean you still don't maybe want to have the patient come back in 2 weeks, but we feel pretty confident this is just a denture sore due to trauma or inflammation. This is a really fantastic approach to really differentiate between things that you see every day that you assume might be benign, but this way we can confirm it. So we have to have a basement membrane. So ulceration, a wound, a fresh bite is going to show up as dark or black because all we're seeing is that stroma. So definitely want to stress when you see an ulceration, something that's an open wound, follow your standard protocols of assessment and referral. Here we see a lesion lateral border of the tongue, but if you notice it's linear, so oral cancer doesn't grow in a linear fashion. These tend to be bilateral, and when we rub across it, it turns green, which is awesome. But we always stress, this is indication of irritation that we want to resolve. So maybe this patient needs to have a consultation with the dentist about getting their crown placed, or maybe opening up their bite with like Invisalign or something. So most common thing you see with VELscope is irritation associated with cheek biting or cheek sucking. The great thing is 90% of the time these will blanch, but if you have a chronic cheek biter and they're just gnawing on their cheeks all day long, it may not blanch because it's like a hematoma. So you definitely want to consider, getting that patient into a night guard before you consider referring them to a specialist. So we have to have a diagnosis. So here, this lesion doesn't look normal clinically. Under VELscope, it's not normal, but when we rub across it, it turns green, right? So just because something blanches doesn't mean we ignore it. We always want to figure out what the cause is. And if we're not sure, please still consider referring just to get a diagnosis, even though we believe it's benign. And obviously, in this case, erosive lichen planus. So this is the anterior lateral border of the tongue. This is posterior. And this is the left side of the tongue. And if you notice, as the clinician is rubbing across it, stays dark. And so, but before they even pulled their VELscope out, they did a white light exam, and they say, Mr. Smith, I noticed some dark maroon areas on the side of your tongue. Do you know what's going on? And the patient's like, oh yeah, I bit the hell out of my tongue last night. And so this would make sense, right? Because oral cancer is not going to grow in this type of presentation. The reason why the clinician is rubbing this area, because in asking the patient, Mr. Smith, I could see maybe while biting your tongue caused some trauma, but this doesn't necessarily correlate with your bite. If that lesion was there, patient wasn't sure, and so patient comes back in 2 weeks. So this was out, but this is an ecchymosis or hematoma that obviously was pretty traumatic and resolved after 2 weeks. But if this was dysplastic or cancerous, it would not blanch. So this is what it would look like. Now, I would stress that usually when you have something this traumatic, patients are going to remember when they jabbed themselves really hard or bit themselves. But to be safe, have them come back in 2 weeks just to make sure. So we have to know when we're blanching. So like amalgam tattoos are not going to blanch when we rub across them. When you use that blanching technique, make sure you blanch the entire lesion. Just don't go down the middle because you could have inflammation associated with dysplasia. So here the left side was inflammatory, but the right side was actually dysplastic. So a question that might come up, and the great thing about working with the medical field is false positives never come up. I mean, I'm quite frank, it's amazing how it seems to be very concentrated to dentistry. But it's just important to help share with your students that this is not diagnostic. Like a mammogram is not diagnostic, it is screening. And if something's identified and you go through a process of assessment, and then follow the protocols as we recommended. Obviously, unilateral reg shape persists for 2 weeks and does not blanch in either one of those visits. Then at that point you refer, and God willing, it's not cancer, right? We're not trying to find cancer, but there's this misnomer. If something is not cancer, then it's a false positive, which is completely opposite from the truth. But we're identifying a lot of abnormalities that obviously require a biopsy to confirm what that diagnosis is.
Quick question about that.
Yes.
Is there like a general release form that you guys have like a template for, just stating that so that the patient that's getting it knows that it's just a screening and signs off on it being just a screening and not a diagnostic?
Well, we have a waiver form that people use normally and you can modify it to Word document. It's usually what people use if they're charging a fee, and it's more of a, education device. But from an FDA perspective, we are a screening device. So I guess in theory, I
Just
can
don't
provide you that.
come back and bite us.
Pardon me?
I just, because these aren't like, because the patients that we see aren't necessarily, I mean, they're patients of record technically of our program, but we are not their primary, care dental office. I just think maybe it'd be best if we have some sort of a release form or a waiver form. Cover ourselves, I guess.
Sure, I can provide you the waiver form, then you can look at it and see if that sort of fits what you're looking for.
Okay, thank you.
And the great thing is, well, we'll get into the picture taking and so forth, because I think that'll be helpful too if you need to communicate potentially with another clinician. So the same process of assessment under white light is going to be the same thing under VELscope. Here we see a little area. I don't know if you'd be overly concerned. Looks like maybe a little scar. And now under VELscope, we see definitely an area of concern. So this is unilateral. It's a regular shape. It persists for 2 weeks. It does not blanch when we rubber cross it in either visit. So that says this is abnormal. That requires further assessment. And that means referral to a specialist for further consultation. At that point, the specialist felt a biopsy was warranted and the diagnosis come back as CIS, which is fantastic. So we caught it as that in that transition between precancer and cancer, which means we're not going to have chemotherapy or radiation or chemotherapy. And we're not going to lose half our jaw. This patient was referred for the polyp. Thank God the polyp wasn't for the polyp. They may not have found the dysplasia and CIS located adjacent to it. If you notice, the polyp is actually benign. So these leukoplakias we tend to see pretty regularly. They tend to be benign, but the problem is we don't really want you to guess. So these were examples of two patients that were part of a study where these lesions were in observation mode, because there really weren't any changes over that period. But this first one, we're not observing anymore. So it's unilateral, it's a regular shape, persists for 2 weeks, does not turn green when we rubber cross it. And at that point was confirmed as severe dysplasia, which is fantastic. We're not losing half our tongue. But the reality is most of these lesions you actually see are going to be benign. They'll be green or light green in color. That tells us that it's nothing of concern. Now, it doesn't mean we ignore it. We always want to figure out, is it a sharp edge? Is the patient biting on their tongue? And we recommend if it doesn't resolve within 6 to 12 months, then consider following up with a specialist. So this patient was referred for the hemangioma on the lip to oral medicine department. And you can see this is the lesion that was found that wasn't picked up. And this is a stage 1 squamous cell carcinoma. So our goal is to find dysplasia. So again, unilateral regular shape persists for 2 weeks, does not blanch. And then our last picture. So this is why photo documentation is so critical, is to really be able to document these lesions that you may see under VELscope that you don't see under white light. So you reference how you may have a patient that of record that's not your patient. This is where taking pictures and sending that image to a specialist and or their clinician may be beneficial. So you got the iPod set up. Did they download the VX app on the iPod?
Yes.
Okay, sweet. So it's real simple. It generates a case number. If you haven't played with it already, the case number is automatic.
Okay.
Okay, so when it says capture image, it'll have 3.
Put this together and I
Okay.
put this together. But what I couldn't do is get this to go on there. I couldn't figure out.
We couldn't figure out how to get it on to stick on the
Gotcha. Okay, so let's do this. So take off the blue cap on the back of the VELscope.
oh, okay. Oh,
All right. And well, hold on, before you put it on, I'm going to tell you a little trick. So at the top of the adapter, there's going to be 2 little, turn on my light here. There'll be 2 little notches.
okay. Yep, I see those.
You see those?
Mm-hmm.
So you want to start, and like you'll have a tooth right in between those two notches.
Just one
Good
second.
attendance, RC not afraid, John left hand, Aria red star, Georgette Gardner. Again, RC
That made me
left
feel
hand are not afraid, John left hand, Aria red star, Georgette Gardner. Thank you.
Go ahead, sorry.
That's okay. So there's a notch sort of there's a tooth, if you will, in between those two notches.
Yep,
So on your left side, hook that tooth up so it fits right into that sort of 11, 10 o'clock
oh, okay, yeah,
notch, and then
Okay.
twist to your right. And don't twist it all the way. So you want those notches to sort of be at like a 30, whatever, 130 angle.
it's, oh, no, I'm just not smart, I swear, I'm sorry.
It might be tough when you first put it on. There you go. Oh,
It's just,
I couldn't to get it on. I tried.
let me see.
Kara's gonna try.
so you want to hold it, actually hold it up at the top here, like this, get a little more leverage that way, as opposed to, and it's tight when you first put it on, so.
Is it kind of at an angle though?
You're at your one click off, because there's 3 clicks.
Oh,
It would probably work that way, but it will look more normal if you start it 1/3 of the way around.
oh. It seemed to be being like one click is off.
So
Sorry.
you should, those three teeth on the adapter should fit right into the 3 teeth or 3
Made it
openings.
in.
Okay, so they're in. Oh, you got it. Okay, sweet.
Okay. It's just, you have more give, I have more give to pull it even further down. Should I just leave it where it's at?
Yeah, so, and that's what I'm saying. So I like to, so where you have it, that way you can turn it vertically or horizontally.
Oh, okay, okay. That makes sense. All right.
The reason I
Oh,
like to
this
do
is
it.
good.
Yes. Well, I think actually the vertically is better, and I'll tell you why. So if you can turn it till it's vertical.
Like that?
Yes.
Okay,
So when you open up the app
okay.
and you're ready to take your picture,
What's our
and
passcode?
you have to play with it a little bit, but you can use your thumb to take the picture then as opposed to having 2 hands. So it just makes it easier to
Oh,
your
I see
picture.
what you're saying. So you
Yeah.
can just press the home button.
Well, when you open up the app, you'll see capture images, and then there'll be on here, see where it says take photo. There's a take photo button that allows you to just take your picture with, and you can again use your thumb with that. So you have a free hand if you need to.
Do we have to be on the oh, we are on the Wi-Fi. Is the app on here already?
Yeah. I downloaded the app. It's LX something, I think, or
VX. Yeah.
VX.
Mhm.
I don't see it on here.
What does it look like? I'm sorry.
It looks like this.
I can't.
Are
I'm
you-
sorry, it's not showing.
Go to the App Store because it was the last app we downloaded. Sign in. You know what you need to do? You need to verify.
Oh,
You need to check the Montana,
Oh,
Smiles Across Montana, and then verify because it wouldn't let me go any further with the app. Now
Sorry.
that I remember, I downloaded it, but it wouldn't let me open it because you needed to verify your new Apple account.
Okay, I'm doing it right now.
We were only doing like 37,000 things at the
Yeah.
same time this morning when I did this.
How dare you. Well, it's really, so once you download the app, just play with it, you take images through there. It's really simple. The key is that it's going to generate a case number for every new patient.
There you go.
And then you're going to have to, if you want to store images on here, then just write the case number in the patient's chart for reference so that you can obviously go back to those images for, consultation, referral, and or potentially send those to the surgeon. Sorry.
Okay.
Wrong way. so where are we going?
Find my iPod now enabled. And now we should be able to go to media and Apple Store and sign in.
So just as you have conversations maybe with eventually with medical colleagues or obviously your nursing students, as they have conversations with potential physicians, there's so much clinical evidence to support the efficacy of the technology. So they can just go to VELscope.com and find it. But it's pretty substantial in terms of how it works and how effective it is in terms of identifying precancers and cancerous lesions. So I think we talked about this a little bit. There is a code for reimbursement for dental. It's rarely covered. I'd be really interested, for any of nurses that you work with that are in private practice at all, a submission for this medical code, which generally gets covered, my understanding, a lot easier than the dental code does. Under dental, it's probably on average about $25, or what most offices charge. I have no clue in terms of medical. So, but there is a code for medical. So one of the things that we talk about is make sure that when you're having a conversation with the patient, let them know that it's completely safe. There's no radiation. There's nothing that causes damage to cells. It's a safe blue light, and they'll feel a little warm. The reason being is sometimes you'll have this 1% of patients, they feel warmth and they think it's going to burn them. So just let them know they feel a little warmth, they hear a little fan, but everything's okay. So the examination process. So let's show us. So we're going to have our VEL sheath that's going to go over the unit. Sorry, I should have this ready. So the VEL sheath goes over the unit first for asepsis, obviously.
Oh,
There's
before
two
you put
opening-
the, okay.
Oh, before you put the thing on,
Yeah, it's easier before you put the cap on.
like that.
And then, by the way, you leave this back on, by the way, here. Bless you. For the iPod Touch to see.
Sorry.
Bless you.
My goodness, how do you
Oh,
do
so
that then?
like this pops off because it's magnetic.
Oh,
And then this pops off because I put it on there.
And Mason Beckwell, make sure you get on the wire of this.
This is the throwaway. You replace every time.
oh, okay.
There's a box of them in there.
Yeah, so then your VEL cap goes on afterwards. So this is the little cap that goes
Rita, let's
on.
go to the office, are we here to the office?
Like this, so it's like a, for your hand.
Yes.
Oh, okay. Let me put those two things back on.
And then you put the little cap on the front.
Oh, no, is that right?
Mhm.
Okay.
And then this goes like this.
Great.
Yep, so you're good to go then.
Yep.
Obviously, again, you have to do a white light exam first. You've done your extraoral and intraoral, and now you do your VELscope exam. So I'm going to make the assumption most nurses aren't going to be wearing loops. So with that, normal processes, most people feel, they usually put it up against their eye. Everyone's different in terms of level of comfort. I would say people, once they get comfortable, end up probably being about 3 to 4 inches from behind the VELscope. One eye or two. Again, everyone's different in that regard. So you have to just get with how you feel comfortable. The key is, though, the distance from the patient. So we want to be 2 to 4 inches from the mouth of the patient. So if you notice here with the clinician, they're about 3.5 inches away.
Okay.
As soon as you turn on the light, you'll see the blue light, obviously. It's instantaneous. So obviously you're teaching your students how to do an intraoral exam. So the same process of your intraoral exam is going to be the same as you're doing with the VELscope. One side, obviously vestibule, other side, floor of the mouth, lateral borders of the tongue, back of the throat, obviously the palate. So 2 things that I would suggest in terms of making a slight change to how you do your exam is, first, when we're looking at the cheeks, most people tend to retract and just look straight ahead. My suggestion is either have the patient turn their head and look contralaterally or just turn yourself. And we want to try to be as
What practice?
opposite
What practice?
opposite of the tissue that we're focusing on. So extraorally. So contralaterally, so looking at one side, the other. Same thing is now too with your tongue. If you're used to using gauze, pulling the tongue and then your mirror to get exposure, obviously you only have one hand now. So my suggestion is have the patient stick out their tongue and then use your mirror to get further exposure as you do your exam further back. Does that make sense? So those would be the two modifications. Obviously, we have to make sure we get great exposure, to pressing the tongue to see the back of the throat. The key, I guess, one key part though is whether, I don't know how you train, if you prefer to have the patient sitting up when you do the exam versus laying back. I was talking to this oral pathologist that he really recommends have the patient sit up first, if at least when you're looking at examining the back of the throat, so that way their tongue's not falling back. So you tend to get a little more exposure that way and less gagging associated with it. But in and out, left and right for the mouth. One way to do it is maybe look at 3 finger breaths as an indicator. It's when you first start, just to give some sense of distance. If you find though, it seems like you're starting to turn grayish color, stop and look. So a lot of times you'll find yourself, you're leaning back and you don't even realize it. So we want to stay again within 2 to 3 inches from the oral cavity. Again, goggles are for the patient. Up and down, left and right for the mouth. And again, it shouldn't take more than a minute and a half to do a thorough exam. Questions on that? Concerns?
No.
Again, if you wear loops, for those that do wear loops, then you can establish your normal distance with your loops on first. So you establish your distance first with your loops, and then you bring the VELscope in. So we're going to maintain our normal distance with our loops on if you wear loops. If you can turn off the overhead lights, great. You'll get greater contrast. This was meant to be used in a fairly lit operatory for practices that just can't turn off the lights because the whole office goes off. But if you have maybe an open window with sun coming in, that's where I find the sunlight tends to counteract the fluorescence. So if you can close the shades down, that would be great. That's not for you. Really don't have to do with that. So obviously, if you see something suspicious, doesn't resolve, still there after 2 weeks, then you may obviously want to consider sending to a specialist. Again, that's where pictures come into play because you can communicate that, I think, a lot easier with pictures. But obviously, they're going to need to get followed up with a specialist to make sure that what you see is something or confirm what you see in terms of if it's a abnormality or not. But obviously, it's up to the specialist to determine if a biopsy is warranted. Do you guys, do you refer patients to a surgeon locally? How does that work normally?
So we would have to, we've mainly seen young kids, we've,
Okay.
In the nursing facility, then we refer to the nursing facility to send them whatever's local, so.
Gotcha. Well, we do have a service, just FYI, that if you see something suspicious, not sure what it is, you can take pictures of them, patient history, no names, but smoker, drinker, age, so forth. If the lesion blanches, and you send it to us, and we actually have world-renowned oral pathologists and oral medical practitioners that'll provide guidance as to what they think it is. And
That'd probably be better than the other.
Yeah, so it's pretty thorough. It's amazing how these guys see something and you think it's no big deal, and they're like, this needs to be biopsied immediately versus something else. It's like a just gargle with some salt water kind of thing. Pardon me?
Is that a website that you go to upload all that information?
Not yet, actually. So right now the process is a little bit it's somewhat manual in that if you actually send me the pictures and there's a form you can fill out, just sort of like a patient history form. If you send that to me, then I refer to the clinical director. That way I make sure things are getting followed up with appropriately. And then the report will come back in terms of those details. So,
okay.
Yeah, so you can just email that stuff to me. I'll send you the form with the patient consent form as well.
Perfect.
Thank you.
Oops, that was it. Nice. So I'm going to send you also a video. It's from this phenomenal oral pathologist who really does a thorough example of how to do a white light or VELscope examination. I think just want to stress, and this is really why I throw up this slide here, is that we're not trying to make you oral pathologists. All you need to do is confirm if something is abnormal and abnormal of concern. If it's abnormal of concern, it doesn't blanch, it persists for 2 weeks, not sure based on Q&A from the patient what it could be, and therefore may require further consultation. But with that, to your point, this is not diagnostic. And so the goal being is, as we screen, we're going to be able to more effectively identify areas of concern that hopefully are precancerous. And actually, the majority of things you actually see with VELscope, you're going to confirm are benign. So hopefully on a daily basis, you'll find it beneficial in that regard. So any other concerns, questions, issues?
No, I think what we need to do right now is we probably need to review that. We're having trouble getting our app ready.
No, it's ready. I
Oh, is it
got it.
ready? So I think we just need to play around with it a little bit with each other, and then probably after we watch your video, and then we'll be ready to go. And we've got this crazy clinical schedule this week, but we want to be using it on Sunday because we have just more adults that have never been seen by anyone. So we're putting on a big migrant clinic. So there are people who don't have any access to care at all. So
How many people do you think you'll be seeing?
oh gosh, 50 some, I don't know.
Okay. Well, definitely. So, you know what? I'm glad I bring this up then. So, you have your plug.
You only have like,
No, I have boxes of them home.
So the plug goes into the base, right?
Yeah.
Here's your base,
Yep.
and the plug goes right in, right?
Mhm.
In terms of care for the unit, really the battery, there's a rechargeable battery. It'll last 3+ years if you use it pretty regularly. So when you're finished using it, put it back in the charger base. However, so if you're doing like a a full day screening event, like you're doing 50+ patients potentially, you're not gonna have time to put it back in the charging base and recharge it, because the battery will only last maybe 15 minutes, okay? Like on one charge. So what you do is plug the unit directly into the cord. You see that?
Okay. And then
And
you
then
can
you
be
can-
using it. Okay.
use it
Yeah,
all
we
day
saw
long.
that. Yeah, that's awesome. Thank you.
So it makes it a little easier. Just be careful, try to not pull too much so you don't want to, break the base, or the connection of the cord, but it just makes it, and it'll get warm. Just FYI, it's okay. If you're using it nonstop, it'll get warm. It's okay. It's perfectly normal. It won't harm the unit. The unit's specially made so that if it overheats, it'll shut off, or, if something else, it's got some other indicators to protect it from, causing damage to itself. So with that, I guess my only request is, hopefully, if you find something, take some pictures. I think those are really the best things to share with not only for yourselves, but your students. And in the meantime, once you get some of that material that I sent you, if there's something else you think need, let me know. And your learning curve is usually about 5 to 10 patients. So like I said, if you're doing it on each other, 4 or 5 times, you're going to feel comfortable. It's not really about what you're seeing. It's just getting comfortable with your angles and your distance.
Just like
All right.
Yeah. Thank you so much, Evan.
Yeah.
Thank you. Well, have a
And
great
if-
program. Let me know if you
Yeah, I'll
need
probably
anything
reach
else.
out sometime next week to kind of let you know how it went.
Awesome. Please do.
I hope your travels. Go ahead.
I'm sorry. Actually, so now I have a serious request. Oh, perfect timing. So, no, really, because we're about to launch our new website. It's really exciting. And we have so many testimonials that we have on our website now. Amber Young just did shared her story. So what I would ask you to do is, if you wouldn't mind, have someone do a quick video of what you guys are doing and show someone doing an exam and what it's for, because the reality is it's not what VELscope does, it's about what you guys are doing and how important it is to
Definitely.
everyone, right?
I'll write that down.
I'll send you a reminder in the email.
Okay, thank you. I'm like, yeah, we could definitely do that.
Awesome. Alrighty, well, have fun. Good luck.
Well, thank you
Need
so
anything,
much.
let me know.
Thanks for the opportunity,
This
Evan.
is awesome.
Thank
thank
you.
you.
Enjoy.
All right,
Bye-bye.
see you later, Evan. Bye.